Hello everyone, and welcome to CK Med. My name is Clark, and I'll be taking you through Thorax and Autonomics today. We've covered some of the things that we're going to be discussing in our upper limbs video. However, I'm going to go a little bit more into depth of the autonomics today, and definitely dive down into our thorax, trying to keep away from our upper limbs, so I don't have to kind of cross over too much. To start things off, it's nice to understand, obviously, the basics of what your thorax is for. Step one really likes getting, do you understand everything? Not only just details, not only physiology and anatomy and microbiology and everything, but do you understand the general concepts that come to medicine? And whether that be asking or answering questions specifically about how to answer questions that patients have for you, such as what is this disease or what is this area of my body for, but also for your general understanding of what an area is, or what an area of the body is used for, or the function of it. Even when it doesn't do anything or move around specifically by itself, everything usually does have a function, except for the appendix. It serves almost no function other than there's some lymph tissue there and it causes appendicitis. So then we can name a disease called appendicitis and we say, hey, there's its function, is to have a disease in it. But most of the other body parts do serve a major function. And as far as the thorax and the thoracic wall, there's two things that it's important for. One is protection of vital organs and to sustain life, such as the lungs, heart, spleen, and liver. But it also serves the purpose of attachment points for muscles for respiration and movement of limbs. It's very important to know that there's attachment along these different muscles that allow for different things to be moved. And we'll be talking about some of those today. So first things first, since we're talking about moving limbs and attachment to our thorax, we do have some muscles of the chest wall that we are wanting to talk about. And one of those particularly is larger in some certain guys that work out a little bit too much in the gym, and some that are definitely not found there in people like me that are super skinny. And those are going to be your pectoralis major and minor muscles. The purpose of those muscles are for internal rotation of your humerus and for adduction of your arm, bringing it in towards you. It also serves the purpose of actually a little bit of flexion at the shoulder. And you can do that via push-ups. Push-ups allow you to do this, or chest press, or bench press. And that's the function of this muscle, is allow for the limb to move kind of forward and spin inward. And we all know that kind of basic workout and what those muscles do. The pectoralis minor, which is found under the pec major here, runs down from the humerus down, and we talked about this last time. It's very important for the axillary artery, as it divides the first, the second, and the third part of the axillary artery as it goes through the shoulder. And that's the very important muscle that divides that. And yes, that is a question that often comes up when you're talking about the axillary artery, and it says, what's the structure that divides the sections? Pec minor. Always remember that, okay? Next muscles that we have here on the chest are your serratus anterior muscle. We talked about that with upper limb. It's important for protracting the scapula, allowing for our humerus to be lifted up over 90 degrees from our trapezius muscle, which is described and shown right here, which hooks onto the scapula here. Allows for yanking of this, allowing for the whole scapula humeral unit to be kind of lifted up. And then lastly, our other muscles that kind of hook in here to the arm, at least, of our thoracic wall, are our lat or latissimus dorsi muscles, which are controlled from thoracodorsal, and blood supply from thoracodorsal as well, nerve and artery. If you can remember where thoracodorsal comes from, that comes off of your subscapular nerve along with your circumflex scapular. Circumflex scapular continues like this. Thoracodorsal comes down, and now you have your main branch of subscapular that goes into your axillary artery up here. Axillary artery. And then lastly, we talked about this in our abdominal wall video. If you're in term 1, you'll have this video in term 2 when you get there for your abdominal anatomy area, but you might have briefly touched upon it upon the abdominis or external oblique, rectus abdominis, internal oblique, and your transverse abdominis muscles that make up the wall of your abdominal body rather than your thorax. But we're here to talk about thorax today. So if I dive further into the muscle, other than the ones that are moving kind of the limbs or the basic large body structures, what about what happens in the thoracic cavity itself? Or not just the cavity, but the thoracic wall itself? Well, that comes down to multiple different things. We talked about our serratus anterior, which is mentioned right here. That kind of attaches down onto a lot of ribs. And so if I stabilize the arms, so if I kind of tripod myself, I sit down on my knees and I put one arm on the ground and the other hand on the ground, and I stabilize my arms to the ground, stabilizing my shoulder and my scapula, I can actually use the serratus anterior to rip apart the ribs, not rip apart, but obviously open up the rib cages, because it's going to contract and pull each of the ribs out this way, opening the chest cavity larger, allowing for respiration. And this is used in accessory muscles and accessory respiration. Now we'll be talking about this in just a little bit when we get down to the diaphragm, but this is one of the muscles of accessory respiration. Other ones come down from the top, which are your scalenes. These are important as well, and you can actually see this. If anyone is in respiratory distress, you're going to see them trying to breathe, and you're going to see the scalenes in their neck contracting. Those are those muscles there. And then we have other ones as far as that work normally in our chest wall and can be used for accessory muscles. And those are your internal and your external intercostals. Now, what this kind of diagram shows is pretty much to pick apart and look at the three layers of our intercostals: the internal, external, and then the innermost intercostals only in certain areas. But our internal and external have a defining feature that separates them. You can see the direction of the fibers going down and out for your internal, and then the ones that are coming in and down as well, and those are your external. And so from out to in, right, going inward and down, that's your external, versus from going down from in to out, that's going to be just like this wonderful gentleman down here. If you can remember what movie this is from. If you don't, you need to stop all medicine and please go watch Iron Man, and then come back to this, because you need a little bit of break if you haven't caught up on Iron Man. And so if it starts and goes down, but down and out, then that's going to be your internal intercostals. And this is just something they simply define, not only where the fibers are going, but what is their function. And so you have to kind of associate which one is going to lift the rib at what certain time. And what I mean by that is distal rib. So if I have the spine right here, this is my spinous process here. I have my transverse process. Remember, we talked about this with our thoracic, or our back and spinal nerves, and then we have our attachment of our nice little rib that runs out this direction, right? So we're wanting to figure out, if I contract this muscle, am I going to be having an attachment here that then when it contracts, it goes up this direction. If it goes up this direction, then I open up the chest wall and instead and lifts it up, where instead if it actually contracts to where it brings the rib downward, and that is going to then close. And so your internal and external intercostals are very important for respiration, because your external intercostals, their closest and most solid attachment is further back and more proximal to the spine. And so when this contracts, what happens is it actually lifts up the ribs and lifts up the ribs and lifts up the ribs. And so your external is going to be very important for inspiration. Where on the other hand, the muscle here, the most proximal attachment is actually on the external part here. And so when this contracts, it's going to yank down on the ribs. And when you yank down on the ribs, your internal intercostal is for expiration. Okay, and lastly, our innermost intercostal muscles are important just for maintaining the overall structure and wall of our thoracic cavity. And a lot of these muscles do attach to your sternum, which we're talking about our pec major and stuff like that attach here. But our intercostals are pretty much in between the ribs. Okay, so since we're still talking about the chest wall, there are things that are attached to the chest wall above the muscular structures we've been talking about. And one of those, actually two of those structures, especially in females or overweight males, is going to be your breast anatomy. And those are your breasts. And so important things to notice, obviously, we know where breasts are. If you don't, I don't know why you're in medicine, or maybe you're never mind. Okay, so breast anatomy, pretty much, you have the overlying skin and adipose tissue that's found within here, but then the main kind of structures that you should know, obviously you have the ducts which come out here, and that's where the milk is delivered into the baby's mouth or into the woman's shirt if she has galactorrhea pathologically. But then we also have, as far as once the ducts come back, we have different areas of this, and those continue the ducts all the way back until we get to the lobules, which the lobules are all these kind of globular things back here, and the lobules are only in women. Men do not have lobules, so men do not produce milk. Women have lobules, and therefore they do produce milk. They both have ducts, however, but men, because they don't have lobules, they do not produce milk unless there's some hormonal change that allows for lobules to be produced, which doesn't occur actually. And then we also have, as far as within the tissue itself, we have our fatty tissue, our subcutaneous fat that we talked about, our glandular tissue. We also have lymphatics that run up through here. And we talked about our breast lymphatics. We're going to be talking about that in just a little bit. Again, just to recap, well, the lymphatics that drain out here into our axillary area, if we block this off, then we have lymphedema. And lymph gets backed up, and we have lymphedema. It swells into this fatty tissue. When it swells into this fatty tissue, we have a lumpy area and we have a non-lumpy area. We have a lumpy area and we have a non-lumpy area. We have a lumpy area and a non-lumpy area, and a lumpy area and a non-lumpy area. But it's in very small. And so what we see is actually these little, small little dimples, and this is called peau d'orange. Or pretty much, it looks like an orange peel. If you will look closely at orange peel, it has these kind of pores all over. If we're looking at the breast here, and then we have all these little pores that are found in the skin, and it's usually around here. And when you have lymphedema, these are kind of extra mentioned, so you can see them all over. Definitely be able to recognize what that is. It's called peau d'orange. It's a French word, so definitely look that up just so you never get confused. So when you see a picture of this, that means lymphedema. Lymphedema. And lymphedema can occur from a few things. And as far as this point in your term 1 of anatomy, you should know that lymphedema means I have cancer. Cancer obstructs the lymph, it causes a backing up of your lymph, causing lymphedema, and that's your cancer. An additional thing you might be able to see is when the cancer invades the suspensory ligament of the breast. And so within here, there's lots of little ligaments that hold up the tissue, keep it nice and intact, so the breast has normal shape and form. However, if you obstruct the suspensory ligament, then you have a nice kind of dimple in one area of the breast. And that is when you invade the suspensory ligaments here. And that's an important thing. It does come up on your NBMEs that you have later when you're going to do your step 1, or your BSE 1 and your BSE 2 and your CBSE and your NBME exams for step 1. This does come up for basic understanding that suspensory ligaments, you invade there, you have dimpling, you invade lymphatics, you have lymphedema, which causes a peau d'orange kind of look to it. Okay, so now that we talked about the anterior chest wall, the breast of the chest wall that's associated with limb movements, let's talk about the bottom of the chest wall. And that's going to be associated with your diaphragm, right? Once you get past the diaphragm or go below the diaphragm, you're now in the abdominal cavity. You're not in the thorax anymore. And so that kind of bottom base, your diaphragm, is a very important structure, not only to understand what are the parts of it, how to describe what things are going through there, what nerves are innervating in here, what it looks like on an x-ray when it's pathological, when it's normal, when there's stuff floating on top of it in the pleural space. And in addition, When you have damage to anywhere that could hurt the diaphragm, what should you do? That's more of a step 2 type of topic. But all these things come up and are very important. So for developing components of the diaphragm, there are a few things you should know. First, embryologically, our diaphragm gets formed by multiple pieces. One of them is a large boomerang-shaped tendon, and this is called your central tendon. And embryologically, it was called septum transversum. It pretty much just forms the septum between all the walls of your thoracic cavity to close it off. So it is the dividing septum. Similar as you have septums in the heart parts, so you're going to be learning in cardio to separate the atria and the ventricle. The thing that divides the thoracic and the abdominal cavities has to have a septum in the middle, and that is going to be your septum transversum because it is literally a transverse septum. This is a horizontal plane, and so we call it a septum transversum. And then that ends up making the central tendon in adult structures. And then we also have the two parts of this, the posterior lateral. This is formed from your pleuroperitoneal membranes. This is just this kind of last part, almost from this section right here, the edge bananas of that boomerang, kind of the caps, the protective rubber caps, so you don't cut off someone's head with your boomerang. That's going to be formed from your posterior lateral parts of the pleuroperitoneal membrane. And then we have the remaining musculature that comes from the thoracic wall that helps and aids and continue to form the rest of the diaphragm. And these all come from where muscle comes from, which is your mesoderm. And then lastly, we have that muscle wrap around some important structures that come down through here. One that punctures through the septum transversum we'll be talking about. The other comes through where the muscle wraps around and makes this crotch, also called crura. Crura means crotch, so if you ever see that again, it does actually mean muscle that lays down sort of like a crotch over something. That's called crura. And that's from your dorsal mesentery of the esophagus, forms that part. And then we also have the musculature that opens up over the aorta here before it opens up into the abdominal kind of vasculature that we talk about in abdominal anatomy in term 2. Okay, so as far as that diaphragm, what are the things that pass through it? Well, in first aid, you'll have a little bit extra details than this mnemonic here, but as for now, I want to teach you this. If you want to go and learn what extra nerves or whatever pass through with these structures, feel free, go ahead and find that in first aid. It's in the abdominal section, or in the pulmonary section, sorry, of your first aid. Near the anatomy, they're going to be talking about the diaphragm and what things pass through it. But as far as here and what's most likely taught in your lecture is going to be the I ate 10 eggs at noon. And this is the great way to remember kind of the three basic large structures that pass through at different heights through the diaphragm. And so that the highest height of things that pass through, this is not the highest height of the diaphragm, keep in mind. The highest height is T8, and that is going to be your IVC. So I8, IVC 8, T8. And then once we get a little bit lower, 2 lower, it's going to be 10 eggs. So 10 is T10, eggs for E of esophagus. And then we have at noon, or A of at, is abdominal aorta, and T12. So those are three major large structures that pass through the diaphragm through different areas at different heights. And yes, you can be asked a question. I have a 35-year-old man that comes in with trouble swallowing. And we see that he has narrowing of the lower sphincter of the esophagus. The esophagus passes through what height of the diaphragm? And it lists a bunch of different areas. Please pick that esophagus goes through T10. Bam. Now you have your answer. Now you have your question. Now you know that you're going to get that free point when it comes to the test. Now, one last thing I want to emphasize before we get past the diaphragm. The diaphragm, so we have our thoracic wall. So here's our, like all our ribs or whatever, and our sternum that passes up through here, and here's our other ribs on the other side, okay? The diaphragm does not go as high as T8 as far as the highest. T8 is actually more like here on the diaphragm, but the diaphragm actually comes all the way up here like this, up to about a height of T4. And if you remember what dermatome we were talking about at D4, nipples. Nipples. So if someone gets stabbed at the nipple line or below, we have to assume they've now stabbed through the diaphragm as well into the abdominal cavity. So as a surgeon, or as a doctor in the emergency department, when you have someone that comes in from trauma that was stabbed just below their nipple, you have to assume it hit the abdominal cavity as well. And so they have to take them up to the OR in order to open up their belly, find that stab through the diaphragm, repair it, make sure nothing else is damaged inside the abdomen, and then close them back up. That is a requirement. It is emergency. Make sure you don't miss that question, okay? That's kind of the bonus that you're going to get from this lecture. Okay, so since we're talking about respiratory things, we were talking about the chest wall, we were talking about the diaphragm, let's talk about breathing. So if I were to ask you a simple question of someone comes into your office, they have pulmonary disease, they have cardiovascular disease, and then it simply asks you this: what is a muscle that is used for quiet respiration? And yes, I want to emphasize quiet respiration. The answer is diaphragm, period, the end. Nothing else is used for quiet respiration. However, if you want to make loud respiration, then you can use your intercostals, and that's your chest wall. And that's going to then be doing these movements, the pump handle and the bucket handle. And these things also can be added to, because you can have accessory muscle use. You can have the ones we were talking about, the scaling muscles from above lifting up your chest wall. We can have your serratus anterior if you tripod your arms to open up those ribs, allowing for more space in your chest to let more air in. Just think of it as a vacuum, okay? What happens when you create a vacuum in your mouth to suck up a drink or a soda out of a cup? Well, you start to suck in on it and you want to open up your mouth in a closed space. So you put your mouth around the straw, seal it off around your lips, and then what you do is you try to open up your mouth as big as possible. You are creating a vacuum in your mouth, and that then allows for less pressure in your mouth and greater pressure in the fluid in your drink. That then it goes from greater pressure to lower pressure. Same thing as way as diffusion works, just gradients of pressure, and that allows for that fluid to go up into the straw and into your mouth. The same way it works with your lungs. Well, your lungs are now your mouth, and we have this little airway, the trachea and the mouth and the nose, okay? And then what happens is we open up and try to expand that open airway. And what happens, it kind of sucks in like a vacuum the air from the outside. We create negative pressure in our chest like a vacuum, and then it's comparative pressure to the pressure outside, which is, sea level pressure, 760 millimeters of mercury versus negative pressure. And that then the air wants to go into your lungs or into the vacuum you've now created. So the only way that we can open up that chest wall is expanding it from side to side and anterior posterior, and from the bottom by flattening the diaphragm down. All these ways will expand and open your chest. So if I have your chest kind of drawn like this, obviously you have your lungs over here and lungs over here. I can expand the chest wall laterally. I can expand the chest wall towards me. This is facing towards me, it's not up. We can also expand it upwards from the scalenes, and then we can straighten out the diaphragm, because the diaphragm normally at rest is like this. We can straighten out the diaphragm and flatten it. So now we have this kind of maximum volume in the chest wall that allows for air to be sucked into the lungs, and that's how breathing works. For accessory muscles, as far as the AP movement and the lateral movement, we call these certain things. And the AP movement is going to be your pump handle. And so that's just describing this movement here. It allows for the sternum to open up this way. And now I have more space between the sternum than I had in this little tiny space right here. So I gain this extra space of air to fill in all this area right in here. That is what our pump handle or AP increase. And then we have our bucket handle, and this is lateral dimension. So before we only had this amount of space, and now I have this amount of space. It's not a lot, but this little sliver of space is enough for some air on the lateral side to happen. And this actually, bucket handle, this lateral strength of the muscles, does not occur in very weak muscled patients. And so this does not occur in someone that has someone that's old, that has, like older, I guess, in their 20s or 30s, that have muscular dystrophy. In addition, this does not happen with children with asthma. They do not have this aspect of lateral bucket handle, so they kind of lose that defense mechanism when they need to be able to breathe air. And so that bucket handle is missing in children with asthma. As far as high yield, this isn't that high yield of a question anymore, but sometimes they can ask it, and that's that lateral dimension bucket handle. Children with asthma lack that bucket handle movement. Okay, so I know you might have gone, hey, Clark, that wasn't fair that you gave us an imaging question. What's going on here? Well, let's go ahead and talk about the basics things that you can see in a thoracic image. You might have had your x-ray and CT and all these crazy things. I want to give you some shortcuts that you can do that when you look at different things, you can really identify changes, okay? So obviously, being in term one, you don't have all this familiarity, or maybe you do, kind of depends on your experience with looking at and reading chest x-rays. So let's walk you through some of the basics that you can do. I'm not going to go through every detail here, and you'll get plenty of exposure in your lab and such. But things that I always want to do is always make sure, am I midline first? Is this person facing exactly at the camera, or are they kind of tilted? Are they facing a little bit to the right? Are they facing a little bit to the left? And how I do that is actually I look for the edges of the clavicles. So I can see the edge of the clavicle here, and I can see the edge of the clavicle here. And then what I want to do is I want to make sure my spinous processes are somewhere right here in between this, with equal distance from the edge of the clavicle, equal distance to the edge of the clavicle, and I can see my spinous processes of here, and you can actually see them over here on these guys right here. If this is what's straight and going on here, who cares about the trachea right now, the airway? If this is what's straight, this person is facing towards the camera or the x-ray camera machine when you do this. And so this gets our alignment. That's the first thing you should do, because people like to just look at an x-ray and go, oh my gosh, tracheal deviation, but then this person is like 90 degrees facing to your right. And obviously the trachea is going to be over here, and so you're going to go like, oh my gosh, the tracheal deviation, and then you realize it's a lateral x-ray, and you're like, okay, that's not deviated at all. I can't tell deviation that way. So always make sure you're straight up there. And then you can assess, is there deviation? You can assess the lung fields, you can assess the cardiac borders, you can assess the bones, you can assess the subcutaneous tissue, you can assess, are there any things that are running in the heart, in the GI tract, anything like that? Are the diaphragms where they're supposed to be, or are they higher than they're supposed to be, or higher than they're supposed to be? Do we have phrenic angles here, some phrenic angles, or are they flattened and filled in with fluid, where I should have a wedge down here? All these different things. Are the ribs all nice and synchronous without breaking? What type of image is this? There's a lot of things that you pick up from here, and you might be going, oh my gosh, Clark, you're talking like a crazy person. Why do I need to know all this? Well, I just want to show you the basic things that you kind of can analyze from an x-ray. I'm not going to ask you that many questions involving the pictures. There might be one later, cough, cough. However, it is nice to familiarize yourself what you're looking at, and then looking at normals, getting familiar with normals, and then assessing your abnormals here. And so this image on the left is going to be one of your AP views. So this is someone that's probably lying in bed. They're too sick to go to x-ray, or we just like will a little portable x-ray in. And how I can tell that is I can see my scapula line right here. So this is my scapula line, and that's going to be my scapula that's found over here, and this is my acromial process that's right here, our acromial process here, coracoid process. Then we have our glenoid fossa, and this is where our humerus kind of sticks in here. So scapula. And if the scapula goes into lung fields, it's an AP. If the scapula is way over here and out of the lung fields, or very far off to the distance, this is going to be your posterior anterior. This person is standing up in the x-ray machine. They reach around, keep their arms way out to the side. Their scapula is protracted away, gets it out of the lung fields, and now I can see some details of the lungs. This is very important because I can analyze different lung diseases a little bit better on an x-ray with a PA view. That's one of the things that we see here. The cardiac silhouette, you can also tell, is a little bit larger in someone that has AP because we're very close to them taking this picture, where APA, we're actually a little bit farther away, so we get a little bit perspective as far as here. Cardiomegaly is defined as when you're greater than 50% of the width across the chest. So you want to make sure they're not like this distance across, so here to here. Should not be greater than 50%. If it is, that's cardiomegaly. Make sure that we have our liver, and then you might be going, what's this little bubble down here? That's a burp, actually. And yes, a burp, because that's the gastric bubble. I don't want to kind of go into any further detail here, pretty much. These are kind of random things. I just want to emphasize a AP versus a PA image. Get your midline, and then you can identify all the structures you learned about x-rays, and how you can tell an AP versus PA is that scapula. That's an important thing there. I'm not going to go into too much detail further than this. Okay, so those were x-rays. Now thoracic imaging from a CT scan. It's nice to identify colors. So a CT scan is pretty much a glorified x-ray. A glorified and can be made three-dimensional x-ray. And so what color was bone on an x-ray? Well, let's go back to here. Bone on here is white. And so bone on here is white as well. Why? It's because, like I said, a glorified x-ray. So you can see the bone. That's your ribs that are found in here. You can see your bone here. This is your sternum. This is this. And easy way to read CAT scans, especially if you're doing transverse, is this person. Here's the bed right here. This is the bed. And we're looking as if I cut the person in half. I took their legs off, so just like the magicians do. So I have my little guy's head, I have his belly, and I have his legs, and then his little arms. So we scissored, cut him off, and then we threw out this part. So now we just have kind of his thorax and his head, and now he's all sad. You cut me in half. Okay? And then I sit here and I go, And I have a serious, like a thought bubble that comes off of here. Okay, this is my thought bubble. That looks like the liver. So if I'm looking up at his feet, this is what I'm looking at. So in the thorax, we have our nice lungs. Lungs are full of air. Air is black, so you can see black here. We have tissue with some fluid. That's sort of like a gray or darker gray. If it's fresh blood that pops into an area, that actually can light up pretty bright. Almost like white, or like a very light gray color. And then if it's blood contained within a cavity, then it's going to be kind of a medium gray color. And then our bones, obviously, we're talking about are white. I know this is kind of scrolling really fast. I don't want to really identify all these structures for you and such. That's not the purpose of this. I'm just showing you that I can do transverse section. How do I look at it? I look at it just like I cut this guy in half, threw out the bottom part. Now I'm looking up at him. He's laying on his back. So I'm looking at the bottom. This is the right side of the guy. This is the left side of the guy. And then here's the center of the guy. And what's in the center is the heart, kind of goes a little bit left. And then we have our liver on our right here as that part. We have our spleen that comes down over here on the left. I'm going to circle that as it comes around through the corner. There's our spleen, that guy right there. And then over here, we have our coronal section. So as if I just cut the guy like this, right up through him. Not down the midline, but like, yeah, you should know what a coronal section is by now. So when we do a coronal section, we can see our lungs on our right. We can see our lungs on our left. We can see our heart here. We can see our trachea coming down, and then it's going to bifurcate down here into our bronchus. And that's pretty much the basics of a thoracic CT image. Yes, you might be able to identify different structures once you get to cardiovascular. I'll break that down when we get there. However, for now, just identify, hey, I know I'm either in the abdomen or I'm in the thorax. Well, I see two giant things of air. I'm in my thorax. That's the biggest giveaway you could possibly be when you're reading a CT transverse or a CT coronal, like this guy over here. That's a lung, giant air-filled thing. Why? Air's black. Then I see lungs and ribs all around here. Pretty much a dead giveaway. So I just want to show you kind of the quick identifiers that you see in image and you go, oh, I am in the thorax. Okay, so let's try a little question. Since we talked about the chest wall, you might not have had an abdomen yet, but we're going to talk about some of our interesting things that happen. So let's try this question together. I have a day-old newborn that's seen by the pediatrician. Keep in mind this is a day-old newborn with irritability, difficulty breastfeeding, rapid and labored breathing, and vomiting. So a lot of things are going on here. Pretty much distress is occurring. We now need to figure out. Patient is tachycardic, tachypnic, and afebrile. What we do on physical exam, we see them in respiratory distress, so I'm assuming that they're retracting the muscles. Because it's a newborn, the chest wall is probably going inward. That's sternal retractions. The sternum is very squishy, so it kind of sucks inward, paradoxically. And then we also see a little central cyanosis. So something's going on with the lungs or the blood supply is what this is pretty much telling me. So we listen to heart sounds, and it sounds totally normal, and the labs are with normal. So obviously something has to be going on with our baby's lungs. And so when we look at this picture, we first determine, yes, this is a baby because I don't see any nice ossified edges of the humerus. We don't see that head all kind of hooked in, growth plate closed, and everything like that you would see in an adult. I don't see these bones hooked together very close and knitly. The acromial process of the sternum and your clavicle are not knit together. And so this is telling me this is an infant picture, which is great because it actually fits the stem. In addition, I see the spine is midline. I see my trachea is not really midline. My trachea is actually over here. I see some lung over here. And then I see this kind of glowing thing that comes down here. And you're going, what the heck is that? Well, that is called an endogastric tube, or ET tube. Not ET tube, sorry, that's endotracheal tube. Endogastric tube. And so what we do is that we put this down the patient's esophagus. It should go into the stomach and into the duodenum. However, why is the duodenum or the stomach actually located up in the left lung field? Now this, you might be questioning, that's weird. What happened there? Well, this is called a diaphragmatic hernia. This occurs and it presents with the same exact question that we're talking about here. And so what would I find on physical exam if this person had a diaphragmatic hernia, so pretty much a hole in the diaphragm that allow for abdominal contents to come up here that you can see by following the tube as the abdominal contents carry you into the left lung field. And at this point, you can see that you have decreased breath sounds because the lung is not functioning on that side, and peristaltic sounds on the left lung fields. And these are pretty much bowel sounds. Is how I can describe that. And so that's the answer is C here. Decreased chest wall on the left with subcutaneous palpable crepitus. This is actually something that occurs with a flail chest that you have when you have multiple rib fractures and usually a trauma, which this patient did not have a trauma. Decreased breath sound on the right side. This is the only place that they actually have normal lungs functioning. We have coarse crackles on the left lower lung fields. Well, we don't have left lower lung fields. The left lung is up here in this area up here, so I wouldn't hear anything on the left lower lung fields as far as crackles or lung sounds. And then high-pitched mechanical sounds in the right upper quadrant of the abdomen. This is usually what we're talking about when we're discussing our small bowel obstruction, or SBO, and this is hyperactive bowel sounds, hyperactive. And then lastly, tracheal deviation to the left. Well, obviously we have someone with herniation of stuff over here pushing the lung this way, which then push the trachea, and we can see it over here. That's definitely wrong as well. And so what is this disease? Well, this guy is our congenital diaphragmatic hernia. It's pretty much defined as bowel sounds in the left lung fields. Hernia, or the diaphragm, is kind of absent or missing on the left side, usually on the left side because the right side has the liver. We can have bowel sounds on the left. Depressed hypoplastic lung, hypoplastic. And then everything's kind of deviated to the right. And then if I put an endogastric tube in here, I can see that it loops back into the left lung field. That is enough for me to pick a congenital diaphragmatic hernia. If you see a picture with that tube going up into the left lung field, you know that you're talking about this disease. Don't pick anything else. Okay, so now into a little bit more of the nitty-gritty and how questions are asked. Okay, so that last part pretty much was kind of an introduction, and then we talked a little bit about that clinical of that diaphragmatic hernia. Let's go ahead and talk about some of the things that can come into play for arterial supply, but then some questions that can be asked. This isn't super high yield, but it is nice to kind of know. Okay, so in our arterial blood supply of the thorax, it's first nice to identify what's going on as far as what comes off of the heart. So let's switch quickly over to essentials anatomy and look at this three-dimensional. Therefore, then this picture might make a little bit more sense. Okay, so here we are with our essentials anatomy, our complete anatomy. This is a fantastic application. I love it, I love it, I love it. And so here is our nice beating heart, which is really cool to see. And our heart actually pumps the blood up into the aorta that goes out into systemic blood supply. It goes down to the abdominal aorta to supply a whole bunch of stuff. But also we have all our blood supply that comes off of the aorta that allows us to supply our thoracic cavity. And what are those things? Well, we've talked about this before. Off of our arch of the aorta, we have our brachiocephalic trunk. And this is kind of, again, that extension cord to get everything over to the right side. From that extension cord, we have our subclavian. Our subclavian gives off vitamin C and D, as we discussed in our upper limb. And remember that the eye is our internal thoracic. And that is the second branch of your subclavian. And that's going to be this guy right here. And our internal thoracic goes on the, obviously, the internal side of your thoracic cavity and supplies and branches out to anastomose and meet and supply all the blood supplies of our intercostals, which we have highlighted in orange here. And that's the purpose of this internal thoracic, is pretty much make an anastomosis point of here. And you might say, where's the other anastomosis point coming off of? And that actually comes straight off as segmental arteries off of your aorta. So let's go ahead and zoom in here so you can see what's going on when we get into the thoracic cavity. So you can see that off of the actual abdominal aortic and the thoracic aorta, you have segmental branches that come straight off of here. And these are kind of their collateral segmental branches. And these go straight to your intercostals and become your intercostal arteries, and will then anastomose with our internal thoracic on the front side of the body. And that's kind of the blood supply. I want you guys to just basically understand, comes down from a below and midline, and then comes across, and then from the back it goes from midline across the back and meets to feed all this like chest wall here. We also have superior ones, or one outside of the chest wall, and these come off your axillary artery. If you remember, that was your superior and lateral thoracic arteries. So that's going to be your first and your third branch off of your axillary artery, and that controls different muscles that are found on the further outer attachment. In addition, your superior thoracic continues down and becomes your superior epigastrix down here, plus your internal thoracic, both combine to make your superficial superior epigastrix, which meet at your umbilicus, and that comes into your abdominal anatomy later on in term 2 when you're talking about portal hypertension and caput medusae around your abdomen. I just want to mention that here. Don't worry about it as far as writing down, but just that's kind of the tie-in and connection between abdomen. Once you come down through the thorax, you continue into your abdomen area. So that's just pretty much where that blood supply ends. Okay, so now that we've looked at that blood supply, let's look at it in just a little bit more detail. Don't worry about it too much. Literally, all I want to add in is that instead of just going to your intercostals or going to your ribs and your intercostal muscles that we were just talking about, that anastomosis point, I want you to then also look at this. It gives off a very small branch, and these are your radicular branches that give supply for your posterior and your anterior spinal arteries. It's kind of the collaterals that come in from the side, so that if you have an occlusion of your anterior spinal way up in the brainstem, that it's not going to occlude the entire spinal cord all the way down. That we have these kind of collaterals to continue supplying the spinal cord where it is. And that comes off of your segmental arteries, which come straight off of your aorta. And that's these ones back here. So it goes around intercostals, but it goes off that little bit that goes in towards your spinal cord. And those are segmental arteries that give off our radicular, which then supplies your posterior and anterior spinal arteries. And again, that we described a little bit in our back and spinal nerves. That's where those arteries came from, were from these segmental arteries. Okay, so now about the arteries, let's talk about the veins. So veins are actually very straightforward. Pretty much all you need to know is two names. One, azygous. Two, hemiazygous. And pretty much what this is azygous is an entire vein that drains everything. Everything goes into azygous from our thoracic wall. Everything else from internal organs, lower limbs, or upper limbs are going to be going and ending up in our vena cavas, either superior or inferior. But azygous does all the wall of your thorax, and the wall of your thorax is going to drain into azygous vein. And if it comes from the left side, it goes into hemiazygous and then urozygous. And if it's in left upper, it goes into hemiazygous and then it goes into your azygous. And then azygous drains back into brachiocephalic, and that then goes to your superior vena cava and into your heart. So as far as the chest wall, azygous on the right, hemiazygous is on the left, and ta-da. Okay, that's pretty much all you should know from venous drainage of the thoracic wall. It's not very complicated and probably not as highly testable as you think, other than in anatomy lab. You actually might get this vein pointed at in lab and going, what is that? Okay, so definitely be able to differentiate the left side versus the right for azygous and hemiazygous. Okay, now basic for lymphatic drainage. This is stepping into the pulmonary region just a little bit, but I just want to emphasize the venous drainage other than up in the axillary area is going to be your lungs, and your lungs have pulmonary nodes, which then the pulmonary nodes, because we're talking pulmones means lung, and therefore your pulmonary nodes. And then we have, from there, we have our bronchus, and our bronchus has bronchopulmonary nodes, meaning in between there. And then from your bronchopulmonary nodes, which are all these guys here, we go up to our between our bronchus and our trachea. And so we're going to call that our tracheobronchial. And then once we get up to our trachea, we're going to call those our tracheal nodes. And then from there, they're going to dump into the thoracic duct. We also have ones on the side, which are bronchomediastinal, on top of the mediastinum, which is here. And those are also going to drain into your thoracic ducts. If it's in the top right quadrant of the body, lymph drainage, it goes into your right thoracic duct. If it's anywhere else in the body, including bottom, lower legs of the right and the left and the upper left quadrant, that's going to end up lymph drainage into your thoracic duct. And that's anything, lungs, limbs, chest wall, everything lymph drainage will go into your thoracic duct on the left and lower everything, but then the top right quadrant will go into your right thoracic duct instead. And then as far as our lymph drainage specifics, we already talked about this in upper limb. Remember, for the chest, we have about 50% that goes across for peristernal. Peristernal is how you get cancer from one breast to the next. And then we also have this going through your pectoral nodes, also called your anterior nodes, that then go to the central, and then central goes to apical. Apical goes into thoracic duct, and thoracic duct goes back in the blood supply, and ta-da. So that's kind of the order of things. That's just a recap from upper limb. Okay, now we've covered blood, we've covered lymph. Let's talk about dermatomes of the thorax. Now our T1 is going to be not only just the thorax and above the nipples, but it also goes to your medial arm. And remember, this is your referred pain. We're going to be talking about this when we get to cardiovascular, but referred pain from a MI or myocardial infarction will also radiate to the left arm. Why? Because the heart is on the left. So here's my wonderful heart, okay, on the left. And so it has more nerves from the left. It also has nerves from T1 T2, T3, and T4. These are autonomic nerves, and the sensory travels back with T1, 2, 3, and 4, which gets confused from the dermatomes that are coming back. Then you have your spinal cord here, and all it says is there's pain coming from the nerves T1, 2, 3, 4. And does it say the ones that went to the heart versus the ones that went to the arm? No, the spinal cord is not that smart. So the brain only receives up here, here's the brain, and it says, hey, pain at T1 to T4. And brain isn't dumb enough to say, well, I don't know, is it just from the heart or is it just from the arm? It's not dumb enough to say, since I don't know exactly where it comes from, it doesn't have pain. Instead, it just says, I have pain in both places. So you have chest pain and you have left arm pain. And that's kind of oriented and going over T1 to T4. And T4 is your nipple line. And then T7 is your xiphoid region, the end of your sternum. Is that T7? Okay, so since we're talking about dermatomes, why is this important? Who cares? What do I care about? Well, we just talked about MI, that's why that's important. The second thing is, what if things are growing inside those nerve dermatomes? And then they erupt on the skin in a dermatomal pattern, maybe around T4. Oh, what do you know? This is the T4 dermatome. This is varicella, latent reactivation, also called shingles. Please remember this. If someone comes in and they say, ow, I have a very, 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 very painful rash on my right, and it's in a dermatomal pattern. Period, the end, varicella, shingles, latent reactivation. And it might ask you, where was it found? Where was it hiding? Why is it reactivating? What's going on? Immunocompromised, really old people, HIV. That's going to be the ones that you're going to be seeing this reactivate. Why is it occurring in a dermatome? Because it hangs out in a dermatomal nerve. And so you might think, where is the dermatomal nerve? Well, here's my spinal cord. Spinal cord, dorsal horn, ventral horn, dorsal horn. Okay, there's the central canal. From here, we have our dorsal, and then we have our ventral root that comes from here, and ta-da. Okay, so there's our spinal cord, our roots, our nerve, and our peripheral nerves as well. Okay, so in sensory, we have a nerve that runs in here, and it gives off its little cell body found in here and continues. And this is found a place called a DRG, or dorsal root ganglion. Dorsal root ganglion. And the dorsal root ganglion is a nice giant cell body for viruses to live inside. And so the virus that goes and likes to live in here is called varicella, also called chickenpox. And chickenpox likes to hang out in our dorsal root ganglion. If it occurs here in the body, it just hangs out at that dermatome. So whatever dermatome this is T4 dermatome. And so where did I say? The dorsal root ganglion of the T4 dermatome. That is where this guy was hanging out. Okay, where did he remain latent, or meaning chilling out? Latent means chilling out. Where is he hanging out and waiting to be reactivated? If it's in the face, it's going to be your trigeminal ganglion. It's just a facial cranial nerve that is similar to the dorsal root ganglion, but it's in your skull instead of your chest wall or here at the spinal cord. So those are the two places you might see that. When you get to head and neck anatomy on term 2, it might come up there. But as far as dermatomes for the chest wall, definitely know what the basic ones are. And then when you have reactivation, know it's varicella or chickenpox, called shingles, and that's latent reactivation. Where was it hanging out? Dorsal root ganglion. Okay, so enough about that. Let's talk about pleura. Now this is a concept that's stepping a little bit into your physiology more than it is of anatomy, but I just want to describe kind of the basic things here. Is as this kind of balloon and this guy punching into it, this is kind of a double layered area, and so we have this balloon that's just right around his hand, you know, kind of snug about here, and this is called visceral pleura. And so you can see this is the fist here. So fist is this nice central thing, and you have the balloon kind of wrapped right around the fist, and that's your visceral pleura. And so that's described as that orange. And then we have all the balloon that's left out here, nice and smooth all the way out here. This is parietal pleura. You have the same concept wrapped around your heart, a parietal and a visceral pericardium, but around your heart it's called pleura, and visceral and parietal. And then this space in here is called your intrapleural space. Now this is sort of a vacuumed area space, so that's this space in here. This is sort of a vacuum, and it's kind of pretty much sticks a vacuum and seals the visceral and the parietal pleura kind of a little bit are maintained together. Or pretty much this vacuum space keeps them from flattening. Like it doesn't let the lung completely collapse, and it doesn't let it open and stick all the way out. This is kind of a nice open vacuumed area. What happens if I pop through this, the air gets vacuumed into this vacuum area, and this causes a pneumothorax, which we'll be talking about in just a little bit. So as far as development of the pleura, there's important things you should know as far as developmental problems that occur. You might not necessarily need to know all these little details and stuff like that, but there are some things that are like, as far as, stage 1 of the pleural development, you need to know these structures and stuff like that. No, just know the clinical in regards to pleural problems. First development, and then kind of acquired defects or damage that you can have later in life as well. So for congenital defects, there's a diaphragm eventration. This is when you have defective musculature of the diaphragm, and this leads to paradoxical respiration. The diaphragm does not contract or respire properly, so the diaphragm actually goes flat when you're trying to expire, and it goes up like this when you're trying to inspire, which is opposite. You want to kind of flatten when you're inspiring. Remember how we were talking about opening up that chest wall. And then absence of central tendon diaphragm. Obviously, if you don't have that central tendon, what is the thing that made the tendon? Remember, septum transversum. It's the septum in the transverse plane, the medial part. That's that boomerang. And then if we have defects in different parts of the diaphragm, such as the posterior lateral hernia, this is called a Bochdolek. And yes, this does come up on a lot of shelf and NBME exams, so remember these guys, the Bochdolek and the Morgagnes. The way I remember this is Morgagnes is medial, or right around the sternum. And so I have my sternum here, and then I have my diaphragm, which was kind of going out this way, right? And I have a little hole right in the anterior part, so I have a hernia that goes right behind the sternum. This is Morgagni. Where in the back of the diaphragm here, this is a three-dimensional drawing. In the back, if I have a hole here around the sternal, posterior lateral, this is called a Bochdolek. Why? Because it's in the Bochdolek. That's how I remember that, in the Bok. So if I did the diaphragm here, this is my spine, this is my sternum here. This is where Morgagni occurs, Morgagni. And then this is where, in the Bok, I'll be Bok. That's Bochdolek. Okay? Anterior, posterior. And then tracheoesophageal fistula, don't worry about that. That will show up in lung. Respiratory distress syndrome, that will show up in physiology. Just remember canalicular period. This is just something to keep reminding yourself. You're never going to remember that unless you keep reading it like 100 times or if you've done embryology. But that's not important right now. Okay, so what's wrong, or is something wrong with this chest x-ray? I've given you some kind of insight. If you go back and rewind and figure out all the things I said and 100 things, what did we do first? Want to check that it's midline. Yes, I see the edges of my clavicles, and I see my spinous process in the middle. I see something here. It looks like someone has got a cracked sternum. We put some little circular metal plates in here and twisty ties. So this person probably had their sternum cracked in half. That's one thing that's wrong here. But then we also have something else missing. Well, we have our lung fields, and our lung fields should end off in a nice angle. And do I see the angle? I do not. This is what a pleural effusion looks like. And remember that our lungs have this nice area down here. And if this fills with fluid, you're going to see this kind of meniscus sign. It goes up like this and fills in this corner. And this is called your subphrenic angles. And if you don't see your subphrenic angles, something's wrong, and you should probably tap that and get the fluids. And those fluids, that tapping that we call, is called a thoracentesis. And how do you do a thoracentesis? Well, this picture is definitely wrong, so definitely don't follow along that. It's like a dumb picture. It's almost there, pretty close, but I'll show you what we want to do. So thoracentesis, we have to be very careful. First off, we need to figure out where we're going to do it. So what kind of line are we going to go on? How high or how low in the rib spaces should we do this? And then once we get to that rib space, that specific line and location, then what? What do? Do I do above the rib, or do I do below the rib? So to determine all these different things, it's important to find what space I should be doing this. So if someone has filling in of our subphrenic areas like this, right, I should be going and tapping this area. So how do I get down there? Well, if I go up here in my rib space, I'm not going to drain anything. If I go over here, I'm not going to drain anything, but if I go down here, it will. And how do you determine how far down you can go to get all that fluid out? Is from this mnemonic. Mic map. That's how I remember this. So mic map 6, 8, 10. Nice and easy. 3 even numbers, 6, 8, 10. Mic map. Mid-clavicular, mid-axillary, and paravertebral. Allows for you to do 6, 8, and 10. And you just go up by 2. 6 to 8, 8 to 10, 10 to 12. And those are your ribs, and the spaces are numbered below them. So that's going to be why I labeled it 6, 8, and 10. So you're going to want to go in your rib space 6 or 7 for your mid-clavicular. You want to go in your rib space 8 or 9 in your mid-axillary, or your rib space 10 or 11 in your paravertebral. So that's where you find that. You find your mid-clavicular line, you find your mid-axillary line, and then you find your paravertebral. And then you can go to associated distance down, and you can still tap this pleural space. Once you go to this area, you find the ribs that you're wanting to go into the space. And what you do is you actually take the needle and you put it right on top of the rib, and you go right above the rib. Yes, there's very small vasculature. That's okay, very minimal. You'll get in there, it's nice and safe, and you will avoid this big bundle that's hanging like fruit from the rib above. So you never want to go under the rib, you want to go on top of the rib. Just hit the rib, slide up above it, and you're going to get this nice area that you can drain from here. Don't go under the rib. Why? Because that carries your vein, artery, nerve. And that's bad, okay? As far as the person having pain, when you hit that parietal pleura, it's going to be that intercostal nerve. It's going to be very painful. And then visceral pleura, it does not have pain, so there's no pain fibers surrounding the lung, which is this kind of thing that we talked about. Flail chest is when you have multiple rib fractures. And if you look at this image, fracture here, 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 and 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 here. Okay, so with all these rib fractures and here, with all these rib fractures, I have this kind of nice piece of floating ribs that have muscles holding it together, but I have this kind of area of broken ribs, as you can see, sort of in this area. And this is called flail chest. And why we call it flail chest is, remember, when we make this negative pressure, when we go to suck in air, right? Negative pressure. Well, what happens when we make negative pressure is, if our chest wall is not solid and stable, it's going to want to suck in things, either air from here or try to pull in on the chest wall. If the chest wall is stable, it can't pull in on it, so therefore it only pulls from air. But if the chest wall is broken, then this can be sucked in. And so on inspiration, we actually see this segment of flail chest go inward, where on expiration we increase and make positive pressure, so it pushes outward. So we see a bulging of this area. So it's sort of called a paradoxical respiration or movement of this segment, and that's a classic finding that you see with flail chest. So just imagine this. I have a 35-year-old man in a MVA, or motor vehicle accident. He has severe chest trauma and signs of a seatbelt sign, and he's having difficulty breathing. And we can notice that there's very large bruising on his left lateral chest and paradoxical movement of areas of ribs 3 through 7. What is most likely the problem? Well, most likely multiple rib fractures with a segmental area floating by itself, and this is called flail chest. Please don't miss that question. Super high yield. Okay, lastly, like I mentioned before, this is the last slide. This is your bonus for this lecture. Thorax, as far as the chest wall itself, is not that important, but definitely pretty much from the end of this video, this is all you actually need to know from the thorax. The bonus that I'm going to give you, this is going to help you on step 2 as well. So might as well give you a little bonus jump ahead so you can be smarter than everybody else. This is going to be when someone gets stabbed, just like this guy gets stabbed right here. If you have the nipple or below, you can see that this diaphragm is very high all the way up here. And so you have to assume when you have penetrating trauma of the nipple or below, you have to assume that you have hit the diaphragm here. And when you hit the diaphragm, that means you've now come into the abdominal cavity. So I have to do a exploratory laparotomy, or pretty much I need to cut open their abdomen and look inside and make sure the spleen's not bleeding, the stomach's not bleeding, there's no abdominal bowel contents spilling all over, causing peritonitis, sepsis, and death, and no like laceration to the liver, anything like that. So if you hit nipples down, nipples up here, down, you pretty much have to open up their abdomen and check that out. Bam! That's a bonus of thoracic trauma. That is management. And thanks for watching. Don't forget to subscribe. I hope this is helpful for your understanding of thorax. Next is going to be our video on lower limb, and that should pretty much wrap up a large amount of your pretty much anatomy of the entire body. Second term, you're going to be going into your abdomen and your head and neck, which I'll be covering once you get there. Thanks for watching.